Hello, this is Dr. Jonathan Koren from the David Geffen School of Medicine at UCLA in Los Angeles, California. Welcome to this infographic-based educational activity, which will be focused on severe asthma.
The following audio is part of a certified educational activity titled Targeted Treatment in Severe Asthma, Moving Toward Precision Medicine. Access the entire activity and complete the post-test at www.peerview.com/CFA. Downloadable infographics and additional resources are also available.
I think it's important to start with a definition of what severe asthma is. The American Thoracic Society and European Respiratory Society Task Force guidelines stated that severe asthma requires that a patient receive treatment with an inhaled corticosteroid and another controller at GINA steps 4 or 5 for a period of at least a year, or that the patient be using a systemic oral corticosteroid for at least 50% of the year in order to prevent patients from having uncontrolled symptoms. Some of the characteristics of what we see in patients who have poorly controlled asthma include at least 2 courses of oral corticosteroids during the prior year for exacerbations, and serious exacerbations with at least 1 hospitalization, ICU stay, or mechanical ventilation in the last year. And fairly typically, patients have persistent airflow limitation with FEV1 of less than 80%. If we take this definition and look at about how many patients in the United States would qualify, it's somewhere in the neighborhood of 5 to 10% of patients having severe asthma, and approximately 2% of the entire asthmatic population being considered uncontrolled severe asthma. Over the past decade, there have been some important revolutionary advancements in how we view asthma. This is a very convenient way of viewing this advancement and understanding the disease mechanisms and how they affect the treatment for a specific condition. On the left, we can see the one-size-fits-all approach, where everyone gets evidence-based treatment, but with no real differences dependent on patient characteristics. Next, we look at stratified medications, where we're able to look at groups of patients and, based upon some of these characteristics, provide evidence-based medication. Finally, we reach the state known as personalized medicine, where evidence-based therapy is given on a very individualized treatment basis. And in this way, we really tailor the therapy to what the patient needs most. We've now been able to characterize both the clinical appearance of these patients as well as their underlying pathology to such an extent that we view asthma as a very heterogeneous syndrome composed of a variety of phenotypes and endotypes, which enables us to base treatment on that specific phenotype or endotype. A phenotype is most routinely defined as an observable property of an organism that's produced by interactions of the patient's own genotype with their surrounding environment. And with respect to asthma, some of these things would include clinical characteristics, things such as the severity of the asthma, triggers, which might include things such as allergens, cold air, and exercise, and then the type of inflammatory process that's at play. And this may include things like neutrophils or eosinophils or even the absence of inflammation. And whereas we try to cluster these and get a general idea of a pattern to how these fit together, we don't always find that they suggest an underlying mechanism. And different mechanisms may at times present with a very similar apparent phenotype. The endotype is a bit deeper in that it takes a phenotype or a set of observable characteristics of a patient and is able to identify a well-defined biologic pathway that is typically associated with that phenotype and may help explain certain facets of that specific appearance in that patient. Next is what some of these asthma phenotypes look like. And in this case, we're really focusing on the type of inflammatory cell infiltration as it pertains to the T helper cell 2 type, what we call Th2 or type 2 inflammation. It's a very important concept. We think the majority of patients have a type 2 phenotype, somewhere in the neighborhood between 50 upwards of 70% or even higher, depending on the subset that you look at. It's most often associated with type 1 hypersensitivity reactions, and in this we mean IgE-mediated allergy, patients who are sensitive to house dust mites or animal danders or pollens, etc. We have eosinophilic inflammation as a very important hallmark of the type 2 pattern. And then finally, generally speaking, a positive response to corticosteroids. However, we must keep in mind that there are many patients with classic type 2 asthma phenotype who don't respond even to very high doses of inhaled corticosteroids, which has prompted us to really search for new ways of treating this disease. If we look at specifically some of the Th2 or type 2 phenotypes, these would include early onset allergic asthma, typically comes on early in life, somewhere between 3 to 10 years of age, maybe a little bit older. Patients have classic allergic symptoms associated with this, very often allergic rhinitis, perhaps atopic dermatitis, and in some cases food allergy or eosinophilic esophagitis. Some of the classic markers for this, of course, are specific IgE, as ascertained either by blood testing or by in vivo skin testing. We know that Th2 cytokines are very prominent here, including interleukins 4, 5, and 13, and we know that there is a genetic pattern for this disease. The next would be late onset eosinophilic, of which a small subset have asthma-exacerbated respiratory disease. Typically occurs in the late 30s, 40s, or sometimes even into the 50s. It may begin with sinus disease, which then progresses to lower airway disease. These patients tend to be markedly less allergic, with less allergic symptoms, with the exception that they have chronic nasal congestion and recurrent infections due to sinusitis, potentially nasal polyposis. These patients may be steroid responsive, but many are in fact corticosteroid refractory. We know that eosinophils play a very prominent role in this disease, mediated by the release of interleukin 5 from type 2 inflammatory cells. Exercise-induced would include mild, intermittent asthma brought on by exercise, in some cases severe. We think this is a mast cell-based disease where changes in the osmolarity in the surface of the lung allows mast cells to degranulate and release things like histamine and leukotrienes. Th2 cytokines may also be involved, but to a lesser extent than the above diagnoses. Now, if we turn to the more difficult type of asthma to characterize, that being non-type 2 asthma phenotypes, we've got obesity-related, which typically occurs more often in women than men, often in their 30s or 40s. Patients may become extremely symptomatic, and their airway hyperresponsiveness may at times be bordering on normal. It's difficult to differentiate these patients from patients who simply have obesity and dyspnea due to deconditioning with possible restriction based on the effect of the pannus in the abdomen pushing up against the lungs and reducing lung volume. We've got smoking-associated asthma, where patients may have an asthma-COPD overlap syndrome, which certainly may not be associated with any type 2 or Th2 inflammation. Neutrophilic asthma tends to be a much more severe disease, usually in the presence of some eosinophils. This mixed granulocytic infiltrate is very often associated with low FEV1 and very much is non-allergic in etiology. Patients often have sputum neutrophilia. We believe this may be impacted by interleukins 8 and interleukin 17, although this is not completely clear at the present time. And this tends to respond very poorly to corticosteroids. And some of the things that seem to be present or trigger this are infections, particularly atypical infections like mycoplasma pneumonia, chlamydia pneumonia, or even routine bacterial infections, and environmental exposures, things like air pollutants, including ozone. And then finally, a polygranulocytic pattern of inflammation in patients, which might be considered the least usual or most atypical presentation of asthma inflammatory patterns. Biomarkers have become a very important topic for research as well as institution and clinical practice. And we can see the application of a variety of different biomarkers to clinical practice, starting with blood and or sputum eosinophils. These are a marker of excessive Th2 or type 2 pathway activation, mainly via the effects of interleukin 5, which brings the eosinophil progenitor out of the bone marrow into the systemic circulation, and then finally into the lung. Interleukin 13 is most important, allowing the ingress of that mature eosinophil into the airway, where it becomes a sputum eosinophil ultimately. It's certainly much easier to assess the blood than the sputum, although the sputum will at times show eosinophilia, typically defined as an eosinophil count of greater than 2% of all cell counts in the sputum, in the absence of patients who have blood eosinophilia. A variety of different ways have been used to define blood eosinophilia. Most commonly, it's an eosinophil count of 300 cells per microliter of blood. Exhaled nitric oxide, or FeNO, is an epithelial-derived substance that is upregulated from the epithelium by interleukin 13. It's an excellent marker for type 2 inflammation, and it may correlate with sputum eosinophils to a great extent. We have total and specific IgE. Oftentimes, patients can have an elevated total IgE, even in the absence of specific hypersensitivities, but perhaps most important to the diagnosis and management of asthma are how patients react to specific antigens, such as we discussed earlier, dust mites, animal danders, as well as others. There's a couple of experimental biomarkers. Periostin dipeptidyl peptidase 4, or DPP4, are both markers of the IL-13 pathway. They've been shown to have some predictive value with regard to certain specific biologic therapies that work best in patients with a type 2 high type of asthma, although these are both investigational, and it is yet to be seen whether they'll be used in clinical practice. And then finally, something that has been out a number of years but is not typically obtained clinically are urinary levels of leukotriene E4. These tend to be very elevated in patients who have asthma-exacerbated respiratory disease, and it's a marker that they may in fact be responsive to certain types of leukotriene inhibitors. We're now going to talk about some of the new horizons in the treatment of severe asthma. We've moved into a very exciting era employing the use of a variety of different monoclonal antibodies, which target specific mediators or cytokines that seem to be very relevant to severe asthma. The two categories that are currently available for treating patients with typically severe asthma are anti-IgE therapy, and here we have a medication called omalizumab, and we have anti-IL-5. Two of these, mepolizumab and ruxolitinib, binding to IL-5 in the systemic circulation. The third, benralizumab, binds to the IL-5 receptor alpha, ultimately causing apoptosis of eosinophils and lowering of the eosinophil counts. Omalizumab was released over a decade ago, has been proven to be helpful in patients who have moderate to severe allergic asthma, typically reserved for patients with severe disease because of the cost of therapy. It's given by the subcutaneous route every 2 to 4 weeks, and the dose is based upon the total IgE level along with the patient's weight. It has been recently approved all the way down to age 6 in patients who have uncontrolled allergic asthma, and we've found that it tends to be even more effective in patients who have high Th2 or type 2 biomarkers, including exhaled nitric oxide and blood eosinophils. Some data has shown that the response rate to omalizumab is in the neighborhood of 50 to 60% of patients who are treated, and it tends to have a good duration with over 60 months of observation. Things that we've seen are improvements in asthma control and quality of life. We've seen a reduction in exacerbations, hospitalizations, colds in children, oral and inhaled corticosteroid use, as well as IgE-mediated inflammation. We'll now move on to the anti-IL-5 drugs, starting with mepolizumab, which in fact was the first approved for use. It's given as a fixed dose, 100 milligrams, every 4 weeks by the subcutaneous route. It's approved down to 12 years of age in patients who have both severe asthma and an eosinophilic phenotype. Some of the things we see improve significantly are lung function, asthma control, quality of life, levels of activity, and worker productivity. Exacerbations, including those requiring hospitalization and ED visits, have gone down, along with the requirement for oral steroids and a reduction in symptoms. This drug, like other anti-IL-5, seems to be most effective in patients who have an adult-onset eosinophilic phenotype, often associated with nasal polyps and chronic sinusitis. With respect to adverse events, we found it to be very similar to placebo. Ruxolitinib, a very similar drug to mepolizumab, binding to interleukin-5 in the systemic circulation, is given a little bit differently. Dosing is based upon weight with a dose of 3 milligrams per kilogram given every 4 weeks by IV infusion over a period of 20 to 50 minutes. This has been approved for patients down to 18 years of age, which differentiates it again from mepolizumab, and is given to patients who have severe asthma with an eosinophilic phenotype. I would say that the efficacy has been relatively similar to mepolizumab, improvements to lung function, asthma control, and quality of life, and again, very importantly, exacerbations have gone down, including those that require hospitalizations or ED visits. It's been shown to be effective with long-term use, and again, adverse events are similar to placebo, with the exception there have been a very small number of cases of anaphylaxis in patients receiving ruxolitinib. Finally, we reach benralizumab, which is an anti-IL-5 receptor alpha antibody, given 30 milligrams every 4 weeks by subcutaneous injection for the first 3 doses, followed by a dose every 8 weeks thereafter. It has been approved for patients down to 12 years of age with severe asthma and again an eosinophilic phenotype. And we see the same kind of improvements in lung function, asthma control, and quality of life with reductions in exacerbations, oral steroid requirements, and symptoms. We can think about what drug we would use in patients who currently have severe uncontrolled asthma. And the choice that I'm going to offer you is an anti-IgE drug versus an anti-IL-5. And I think a very rudimentary way of approaching this is in patients defined as having allergic eosinophilic asthma, you could use either an anti-IgE or an anti-IL-5 antibody. And some of this may depend upon whether the eosinophil count is extremely high, greater than 500 or 600, and how allergic the patient's phenotype seems to be with respect to other things like allergic rhinitis. The second group are patients with allergic non-eosinophilic asthma. You could use an anti-IgE And then finally, patients who have eosinophilic asthma but are not allergic or do not have a relevant allergen picked up by skin or blood testing. As an example, a couple of isolated tree allergies in a patient with year-round asthma. Or they've been treated with anti-IgE treatment and have eosinophilic asthma, or they have a very, very high IgE level where we don't think that the drug will impact on their IgE. And in all of these scenarios, we would consider using an anti-IL-5 drug. With respect to which anti-IL-5, I think a lot of it depends on who you're dealing with. If we look at some of the specifics, we can see that there is a difference for the indicated age, with mepolizumab and benralizumab being greater than 12 and restylizumab 18. Mepolizumab and benralizumab are both sub-Q, compared with restylizumab as IV. Dosing schedules differ between these three drugs, with benralizumab being every 4 weeks for the first 3 doses and then every 8 weeks thereafter. To a patient of normal weight, you would certainly consider mepolizumab or benralizumab because of convenience factors. But in a very large patient with a high BMI, you might consider using restylizumab since you can specifically tailor the dosing to higher body weight. And finally, the product insert and most of the data revolve around different eosinophil counts, with mepolizumab and benralizumab greater than 150 cells versus restylizumab, where the data is up to 400 cells. There are no head-to-head studies of these 3 agents, but I can at least tell you that in different patients, they all seem to be very effective. There are a number of emerging new treatment options for asthma. These would include dupilumab, which is an anti-IL-4 receptor alpha antibody under FDA review, tezepelumab, an anti-TSLP antibody, which has recently moved into phase 3 development, as has Sevilla Print, which is a CRTH2 small molecule antagonist. The CRTH2 receptor is the receptor on Th2 lymphocytes for prostaglandin D2. And by blocking prostaglandin D2, prevents activation. This is also moving into phase 3. We first turn to dupilumab, which has completed all of its phase 3 studies and has recently released some of the data. This anti-IL-4 receptor antibody, very importantly, blocks the actions of both interleukin-4 and interleukin-13. The effects of interleukin-4 and interleukin-13 include an increase in eosinophil ingress into the airway, an increase in collagen deposition in the basement membrane, along with an increase in the maturation of cells into full goblet cells, which produce mucus. Interleukin-4 and interleukin-13 also impair the ability of smooth muscle in the lung to respond to beta-adrenergic agonists. And very importantly, interleukin-4 and interleukin-13 both have an effect on IgE production coming from plasma cells. The way that these 2 cytokines vary the most is with regard to the perpetuation of Th2 lymphocyte cells in the presence of interleukin-4 only. Interleukin-13 has not been shown to have this effect. In the most recent phase 3 study, which was recently analyzed, 1,795 adults and 107 adolescents, we found in the overall population, irrespective of eosinophil count, there was a 46% reduction in exacerbations over a 52-week period, with a 9% improvement in FEV1 at the 12-week time point. But if we now focus on subsets of patients who had varying levels of eosinophils, we find that in patients with eosinophil counts of at least 300 cells per microliter, the reduction in exacerbation goes all the way to 67%, with an 18% improvement in FEV1. What's important to keep in mind is that the overall rate of adverse events, including infection and conjunctivitis and herpes, were comparable between the dupilumab and placebo groups, and injection site reactions were more common in the dupilumab group than in the placebo group. Another study that is focused on the efficacy of dupilumab looked at a group of patients who were oral steroid requiring. This group of patients who had been using corticosteroids for the past several months were entered into a 24-week study, including 210 patients. And in that study, we find that patients treated with dupilumab 300 milligrams every 2 weeks, and the overall group had a 70% reduction in their need for oral corticosteroids, along with a 59% reduction in exacerbations and a 15% improvement in FEV1. But in patients with at least 300 cells per microliter of blood, the reduction in the requirement for oral corticosteroids went up to 80% reduction. Reduction in exacerbations rose to 71%, and lung function increased to 25% improvement in FEV1. Again, with regard to side effects, we find that there were more injection site reactions in the dupilumab group than the placebo, and there was a small increase in eosinophil counts in patients actively treated with dupilumab. Some of the other drugs that have gone into development include PillaMap, which is an anti-TSLP monoclonal antibody. What I'm going to show you now are the phase 2 dose-ranging data, looking at 145 patients for treatment group. There was a significant reduction in the annualized rate of asthma exacerbations at week 52 for all dose groups. There was significant improvement in bronchodilator FEV1 at the end of the study, and a greater proportion of patients treated with tezepelumab were either well-controlled or partially controlled by the end of the study. If we divide patients into high Th2 and low Th2 based upon blood eosinophil counts, exhaled nitric oxide, and on a composite score, what we call the Th2 status, which is a combination of total IgE and blood eosinophils, we find that whether a patient has a low or high Th2 profile, as defined by these various biomarkers, that all three of the tezepelumab groups were lower in terms of exacerbations than the patients who were treated with placebo. One of the newer drugs that we've seen going into phase 3 is Sevilla Print, which has now been employed in uncontrolled allergic asthma. We mentioned it's a prostaglandin D2 antagonist on Th2 cells, and what we've seen is significant improvements in FEV1, patients treated for a period of 12 weeks. We can see both the 150 milligram once daily dose and 75 milligrams twice daily dose, which are likely candidates for more advanced development with this drug, did show statistically significant improvements. But I think what's very interesting is that with this drug, given to patients with elevated eosinophil counts, that when we compare placebo and the active drug, there was a reduction in sputum eosinophil counts, which was statistically significant, and it may be pathologically important. Along with these improvements in both FEV1 and in eosinophil counts, there were improvements in asthma-related quality of life and in ACQ-7, which is an asthma control questionnaire, which were statistically significant. When we turn to the non-type 2 phenotype, there are very limited treatment options. We'll very often try chronic macrolide therapy using clarithromycin at a dose of 500 milligrams twice daily for periods of 3 to 6 months. There have been open-label studies of this, as well as a small number of patients who have received double-blinded therapy, and there does seem to be a significant treatment effect. Tiotropium certainly has been shown in their studies to have bronchodilatory effects and effects on reducing exacerbations, whether the patient is allergic or non-allergic, or eosinophilic versus non-eosinophilic. And then finally, something to keep in mind in patients with frequent exacerbations who are very poorly managed with all standard therapy as well as trials of biologic therapies is bronchial thermoplasty. This has been shown in long-term studies to improve quality of life. So in conclusion, certainly asthma is a heterogeneous disease, particularly severe asthma, with multiple phenotypes and potential endotypes. We've learned through very carefully done scientific experiments that certain cytokines and other mediators are important to driving severe asthma, and targeted treatment, which we've developed over the past decade, can be very important in reducing the morbidity of asthma. Along with exacerbations, some of the selected agents can also improve asthma-related quality of life, asthma control, and pulmonary function. And specifically, agents which inhibit the IL-5 and IL-4/13 pathways have been shown to significantly reduce oral steroid requirements, and along with this, show an improvement in outcomes despite the reduction in the oral steroid. On that note, I would like to thank you all for listening in today and hope you found it both interesting and useful.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at www.peerview.com/CFA. This activity is supported by independent educational grants from AstraZeneca LP, Novartis Pharmaceuticals Corporation, and Sanofi Genzyme and Regeneron Pharmaceuticals.